Hi everyone, welcome back to PLAB Talks, your go-to series for structured PLAB 2 revision.
Glad to have you with us again.
So, today's case is one that really requires careful listening. A young woman presenting to GP with headaches and some visual symptoms. This one needs a sharp clinical eye. She's a young female, visibly obese, and she's complaining of headaches along with blurred vision. In this mannequin station, the fundoscopy model shows papilledema.
Interesting.
All right, let's take it from the beginning. What sort of headache history would you want to get?
You go full Socrates, of course. So ask where the pain is, how it started, and its character. Patients often describe it as a pressure-like or throbbing pain. Then see if it radiates to the eyes or neck and probe for associated symptoms, blurred vision, blackouts when standing, nausea or vomiting.
Oh, those visual blackouts especially. That's a big clue, right?
Exactly. And timing is important. These headaches are often chronic and progressive. Ask if coughing, sneezing, or bending makes it worse, raised pressure signs. Patients might say standing or elevating the head helps.
Okay, so we're starting to suspect raised intracranial pressure. What differential should we still be thinking about?
Yeah, you don't want to jump the gun. Rule out migraine, ask about aura, photophobia, meningitis, fever, neck stiffness, stroke or mass effect, neurological deficits, and sinusitis if there's facial pressure. Trauma, recent weight loss. That helps rule out malignancy or secondary causes.
What about risk factors? Anything specific you'd want to ask?
It's definitely. You ask about medications, especially the contraceptive pill, not because it causes this, but it's often part of the background. Also, recent weight changes, infections, or hormonal treatments.
And from there, PMAF-TSOSA, the whole structure?
Yes, ask about thyroid disease, anemia, any family history of strokes or pressure conditions. Social factors like smoking, caffeine, occupation, they all add context. And of course, you ask what the patient thinks is going on and what they're worried about.
Okay, so say you've gone through that and done your fundoscopy using the mannequin, and you find bilateral disc swelling with blurred margins. That's papilledema.
Exactly. That's your clinical finding that tells you intracranial pressure is raised. Now you put it all together. Young woman, visual symptoms, headaches worsened by position or Valsalva, and papilledema. All signs point toward idiopathic intracranial hypertension, or IHH.
Right, so now comes the key question. How do you deliver that diagnosis?
You start with tell, ask, explain, check. Tell. From your symptoms in the eye examination, I'm concerned about a condition called idiopathic intracranial hypertension. Then ask, have you heard of that before?
And what's your explanation?
You say, when I looked into your eyes, I saw swelling where the optic nerve connects. This is called papilledema. It means there's increased pressure inside your head. It's not caused by a tumor or infection, but rather the fluid that cushions your brain isn't draining properly. Then add, this condition is more common in young women, and there are few risk factors, including body weight, but it's not something you've caused or could have predicted.
And how do you check understanding?
You just say, does that explanation make sense? Is there anything you'd like me to repeat or explain more?
All right, let's move into management. What's the next step once you've reached that diagnosis?
The immediate referral to A&E. That's the first move. You say, because we found swelling behind your eyes and your symptoms suggest raised pressure in the brain, I'd like to refer you to hospital today to be seen urgently.
And who's involved in that assessment?
Two main teams. The neurology team to assess the pressure, and the ophthalmology team to monitor the optic nerves and vision closely.
Right. And any advice you need to give at this point?
Absolutely. Driving advice is key. You say, because your vision is affected, I have to advise you not to drive. You'll also need to notify the DVLA. Then check, do you have someone who can take you to hospital today?
And once they're in hospital, what investigations should they expect?
A CT or MRI brain scan to rule out masses or secondary causes, possibly a lumbar puncture to measure the pressure and analyze the cerebrospinal fluid, and blood tests for iron levels, kidney function, and hormones.
Let's say it's confirmed. What's the initial treatment?
They'll usually start IV acetazolamide, which reduces fluid production and lowers pressure. Some patients may also be started on oral medications or steroids. In rare cases where pressure doesn't improve, they might discuss a shunt surgery to drain the fluid, but that's a last resort.
Right. And in terms of long-term management?
One of the most effective strategies is weight loss. It's been shown to significantly reduce symptoms and recurrence. The hospital team may refer to a dietitian or weight management service. Ongoing follow-up will be with neurology and ophthalmology, with repeat eye exams, scans, and possibly repeat lumbar punctures if needed.
And sig zenning?
Say, if you notice sudden worsening of your vision, or you develop a severe headache with vomiting or confusion, please go straight to A&E. You also tell them you'll follow up once hospital reports come back, and hand them a leaflet on idiopathic intracranial hypertension for reference.
So clear communication, urgent action, and long-term planning. It's a lot, but very doable if you stay structured.
Exactly. This is a diagnosis that depends on good listening and careful eye examination, and the earlier you act, the better the outcome.
All right, that wraps up another episode of PLAB Talks. Thanks for breaking that down so clearly.
Anytime. And remember, folks, always trust your structure. It won't let you down.
Catch you in the next episode.